All right, thanks, Alex, so much. It was really nice. And yeah, these are really difficult topics, and I'm going to try not to make them too boring for everybody, but they also kind of haunt us. And as we look at our practices, I hope that this will shed some light on where we are and where we should go, and how we treat older aging patients, which actually constitute a huge part of our practices. So, let's see here. So here are my disclosures, and none of them are relevant to this talk. So the first thing is, why am I talking about this? And I want to go through this a little bit. I think so often we get focused in on what we're doing and how we're doing it, and often we don't spend enough time thinking about why we do these things. And, here's a patient, spondylolisthesis, L4-5. It's not about, this talk isn't about what you would do here or how you would do it. It's about the fact that when you look at these patients, even for a simple one-level fusion, patients have complications. And some of these things are things that we can control in the operating room, but a lot of these things are not. And the question is how do we select and identify those patients who are not going to do well with surgery, and do that preoperatively so that we help them avoid recovery times and the adverse events that come with complications. And, one of the things that I really enjoy doing is spinal deformity surgery. I think we all love the surgery itself, but one of the things I also love is to study spinal deformity surgery. And a big reason is that any sort of complications you get in simple degenerative surgery are multiplied by 100 in deformity surgery because of the invasiveness of what we do. And this field is plagued with the complications, probably more than any other field in medicine potentially. And so it gives us an opportunity to study these things well, and it gives us a great opportunity to improve. And from a research standpoint, if you look at a really successful operation that does well 98% of the time, if you study 100 patients, you only are going to have 2 to look at. But if you look at 100 deformity patients, you may have 30 to 35 patients to look at. So a lot of this talk will be focused on spinal deformity, but the implications of what you find in studying this broadly apply and are generalizable. The other reason I think a lot of this talk will be about spinal deformity is that if you look at what's happened with the ISSG, as they've studied in the International Spine Study Group, outcomes for spinal deformity in adults over 10 years and hundreds of papers, there's really been a minimal incremental benefit. And it's pretty amazing. And maybe there's a little bit of increased complexity of the cases over this time period, but despite all the papers that have been written, we've done so little to actually push this field forward and reduce post-junctional kyphosis and failure and reoperations. And so the lesson here is that while we all want to focus so much on what we're doing and how we do it, there's probably a lot of patients here that have innate patient factors that we need to identify that probably contribute more to their bad outcomes than what we're doing in the operating room. Over the years, there's been a lot of attempts at trying to improve prediction for patients. So one of the first things that we saw a lot of, and we saw in general surgery, was to use these prediction calculators. NISQIP databases, database insurance databases were kind of used to select variables that they found that correlated well to adverse outcomes and complications, and then they'd put some sort of calculation forward that give you maybe a couple percent risk factor of each complication. And when these came out 10, 15 years ago, we were really excited these would start to be implemented in our practice, and we'd all of a sudden be having these like, oh, well, I know exactly what my calculation is for this. The reality is that no one does this. No one has these in our clinics. I've yet to see people really successfully use this, and so there leaves a lot to be performed in that area. More recently, this concept of frailty has grown, and Actually, Vivian presented her research the other day with the pediatric frailty index, and Dr. Shear's done a lot with this as well. But I wanted to take a second and look at how frailty indices are calculated and think about what we're gathering when we look at a frailty index. So most of our patients are actually not frail. What we're actually calculating is an inherent ability of a patient, their reserve, their tolerance for some sort of insult. In our case, our insult is the trauma that we impose on them by operating. But in general, frailty is a vulnerability state with increased risk of adverse outcomes, as they describe this. And this guy, Kenneth Rockwood, he's a PhD who's really led this field. This is his original paper that described how you would calculate this. And this has got like thousands of publications, one of the most cited papers actually in medicine. And what you do is you take something called the deficit accumulation model. So essentially what you're doing is you're looking at any sort of health-related information, and it can really be pretty broad. It could be the person has depression, or they can't walk, or that they have a history of hyperlipidemia. And if you take enough of these things and you actually count the number of things that they have, the number of deficits, you can get a relative number. And interestingly, when they studied this, it didn't really matter what deficit they were looking at. None was really that much superior in predicting survival. So the concept here is if you count enough things, that you can actually get a sense of their disease state. And it probably saturates around 30 or 40 deficits. Like beyond that, you probably don't get a lot more. Below 10 is definitely not enough. So most are in that 10 to 30 range, 10 to 40 range. But that's how these frailty indices were basically created. And the idea is you're trying to get a quantitative measure of this patient's vulnerability state. A number of them have been applied. One of the most common is called the Modified Frailty Index, which has these 11 components. But what you'll see, and it's not that this is a bad paper, but this is what they all show. They show that here's your complications, here's your study group, and that the patient group that had the complications had a higher frailty index. Okay, so what do you do with that? Like, what does that mean? What if a patient has a frailty index of 5 or 4? What are you going to do clinically? And I think that this has been a real difficulty. And while lots of people love to study this and you can look at it, actually being able to draw meaning of this is a challenge. This is a really nice frailty index that was actually devised by the SRS. It's called the Adult Spine Deformity Frailty Index. And actually, Dr. Shear was on this paper, and it really, really does a nice job of applying this accumulation model. They took 30 to 40 things here you can see on the left, and they showed that really every single outcome was related to the patient's frailty, from everything from complications to PJK, reoperation, pseudoarthrosis, etc. This is a lot of things to study. Peter Pashis kind of tried to boil it down into an even smaller list of maybe 20 so that it might be better implemented. And actually, it not only affects complications, but patients' healthcare quality of life at 2 years. So, the issue here, though, is look at what's involved in this frailty index. This was built based on the fact that the ISSG, who performed the study, amazing study, had questionnaire responses for the SRS, they had ODI, they had SF36, and they took selective parts, and each one of those they included as a deficit. But most of us do not readily have all of these questionnaires in our clinic. They don't have access to all of these questions and are not going to take the time to count these things. And so, part of me wonders too, if you really know what the deficit accumulation model is, it doesn't really matter what these things are. Do we really need to know the questionnaire? Now, these seem really applicable to these patients, but do we really need them to be? So we kind of took on a project here a few years ago. I partnered with Jason Moore, who's our director of computational medicine. He's a brilliant PhD who does a lot of machine learning. And I said, can we take a look using these huge group of patients that we've treated here at Cedars, and can we study them using some of your advanced machine learning models to kind of predict outcomes. But what I want to do is I want to take data that we all have. I want to take stuff that when we walk into the clinic, the patient already has most of this stuff at your disposal to use as a clinician, stuff that's already in the EMR, and can we kind of use that to predict outcomes? And they use an auto machine learning pipeline, which essentially uses kind of this multiple iterative process to go through different algorithms, because there's multiple different types of machine learning algorithms, and then also to select the best parameter for each algorithm. So it takes out the human element of this and basically spits out an optimal predictive model for each outcome. And for ours, we decided to look at three things that were reproducible and really had high fidelity outcomes in our electronic medical record, which were prolonged length of stay, 90-day readmission, and whether they were able to be discharged home or not. And without knowing anything about the surgery, how many levels or indication for surgery, just data that was in the electronic medical record from labs, past medical history, BMI, with a pretty decent AUC, which is the area under the curve, we could predict these adverse events. And so this really was promising to me. I thought this was amazing. We only had about 3,000 patients, which in the world of machine learning is really small. And we were able to still do really well with these predictive models. And so this kind of got the gears turning. One of the other cool things about machine learning is that you can take a different perspective on trying to figure out what's important in these models. So in traditional statistics, we all do linear regression. We find the things that correlate that we kind of think in ahead of time might be correlated. We measure, and then we do a multivariable regression. And we feel these things are independently associated with whatever outcome. With machine learning, you can actually plug this into the algorithms and find out how important each of these variables is to your actual outcome. It'll tell you how much did this influence the algorithm that you got chosen. And this is something called the Shapley value of importance. So you can see here some of the things that we would always know that might be implicated here, right? So if you look at readmission at the bottom, patient's preoperative morphine intake and history of chronic pain were the two biggest things that actually dictated readmission. Not surprising. We've known that. Things like age, but other things that you might not have thrown in there, like marital status. How many patients that are alone? We know they're more likely to go to a facility. They may be more likely to be readmitted because they had a fall at home and no one was taking care of them. Things like that. So it takes away the bias and actually allows you to see in a relative fashion how important each of these things are. Interestingly, we found that hemoglobin was a driving factor in two of ours, and so we looked at that a little bit more. Actually, if you look at increasing amounts of anemia and the severity, it correlated to the outcomes. If you look at the patients who had all three outcomes versus the ones who had none, there was different distributions. And we think that probably what's happening is that the anemia is actually a surrogate biomarker for frailty. And if you look at the number of other comorbidities they have with relation to their anemia severity, it goes up. So this is probably a reflection of chronic disease state. And actually, we're probably just picking up a signal of their overall frailty index, maybe in a small way, by looking at that. But, when you look at all this machine learning stuff, it's really great. It's a super powerful tool. It gives you really good prediction. But it takes a lot of data and energy. And if some of these things that they were running would have to run overnight on supercomputers in a really high fashion way. So then I actually took a step back and I said, well, maybe the frailty indices are something we should look at. Like, how much better does a machine learning algorithm improve upon what we're getting from the frailty indices? But I wanted to not lose that part of, like, let's get and study things that we already have in our electronic medical record. So I found two really well validated frailty indices that people have studied in other areas of medicine: heart failure, pneumonia, survival in nursing homes, etc. And they're completely based on the electronic medical record. One's called the Electronic Frailty Index, or EFI. The other one's called the Hospital Frailty Risk Score, or HFRS. Both have been validated in like New England Journal level JAMA papers, and so they're definitely very good outcomes measures, but I wanted to say, well, how well do these things, which also can be obtained in our medical record in the same way, compare? And just like everybody shows, you can see here that if you look at the two electronic frailty indices, if you look at the adverse events, every single one of them, there's a difference in the amount of frailty. So I did what everybody else did. But then I said, well, I want to see how well do they actually predict the outcome. And so we ran regression models. And if you look here, this is an area under the curve for discharge disposition to home. The light blue and the dark blue are the frailty indices. So you can see that they far underperform the yellow curve, which is our machine learning prediction. So we're really not meeting the mark. You know, the AUC is 0.78 versus 0.66 and 0.68. And I said, well, what if we added these frailty markers back into the machine learning, see if they can make them even smarter? Maybe it'll be another data. And actually, it didn't even improve it. So the other two lines there that run along the yellow, the black and the purple, or if you add those frailty indices to your machine learning, it actually doesn't even make it any better. So, you know, we reproduced this with all the outcomes, and you can see that it's kind of the same. And so this has been shown. Actually, the same Kenneth Rockwood guy wrote a paper on this, that machine learning probably does a better job because most of our variables are nonlinear, and it handles that data a lot better. And so even when we broke apart our frailty indices and actually decomposed them, deconstructed them, and then fed all the variables that they used for those frailty index into machine learning, it did better than the frailty index did itself, which suggests that exactly this, that the machine learning can actually handle the data better than traditional statistics. So what I concluded from this is that we need to continue to push these advanced computational methods because the frailty metrics are not going to meet the mark, and they're probably not going to be providing enough predictive power for us to sit in clinic and say, I'm going to do something different for my patient because of this. So I'm going to kind of switch gears a little bit here and say, okay, well, we know that these machine learning models provide us an AUC of maybe under 0.8. So it means that there's a large, maybe 20 or 25% that we aren't explaining with these things. So where is that coming from? Well, maybe some of it's coming from surgical factors, but there's probably tissue level data and health things that we're not measuring in the EMR that are probably influencing this outcome. And we know in spine surgery, the kind of things that most contribute to health and recovery are the health of the bone and the health of the muscle, so osteoporosis and sarcopenia. And I want to kind of highlight that these things are probably concomitant conditions that have really, really, really strong ties to each other. And then in a lot of ways, we probably should not be separating these conditions. And if you look at them in large studies, tens of thousands of patients, there's actually a really strong relationship between the bone mineral density and sarcopenia measures. So these things probably are part of a continuum, and this is both because the pathophysiology of them overlaps a lot. You know, they're both affected by aging, physical activity, nutritional status, chronic inflammation. Both of these things, all of these things kind of affect both conditions. Also, they lay adjacent, so there's probably paracrine factors through the periosteum. Muscle is affected by bone and vice versa. So all these things kind of add together to create this condition of osteosarcopenia. And we know that a hallmark of both is fatty infiltration. So fat infiltrating the bone marrow is a hallmark of osteoporosis. Fat infiltrating the muscle is a hallmark of osteosarcopenia. Okay, so these are probably complex conditions, but have a lot of overlap and probably shouldn't be looked at in separation. Moreover, we know that obesity, because of the role of fatty inflammation, and actually a lot of the chronic inflammatory factors that come from what we call adipokines, or basically molecules that are released from fat cells that signal other tissues, probably overlaps in the pathogenesis of both of these things, and ultimately the presence of all three may be coming together to actually contribute to your frailty syndrome. And there's probably a genetic basis to this that we probably don't even realize as well, and several genes have been described to actually be putatively implicated in both. So how do we, looking at them separately now again, though, how do we kind of evaluate each, and how do we assess them in our patients? So this is probably the most cited paper in the sarcopenia literature. There is this European working group of older patients. This is their second meeting. And basically, this is a bunch of gerontologists and geriatricians and medical doctors that said, how do we assess sarcopenia, which is muscle failure in aging adults? Because it has huge implications well beyond spine surgery. I mean, this is impacting general health, survival, cancer, everything. So this is a huge field. We're just like one little teeny corner of it. But basically, they define sarcopenia as loss of muscle strength, loss of muscle mass, or basically the type of muscle tissue, quality, and then physical performance. So like how well do patients do on a battery of tests? And all of these things, again, have a strong interarray. They kind of impact the other disease states. And, this is probably a really complex thing to study. But, basically they showed that these are kind of the existing, really well-established ways to assess sarcopenia. So just kind of looking at them, we can look at strength. So things like grip strength. How fast can a patient sit up from a chair 5 times? We can look at muscle quantity and quality with radiographic measures. And then we can do physical performance testing with like a short physical performance battery test or one of these time up and go tests, basically to assess patients' physical status. And that should be like a surrogate marker of severity. And all 3 of these have been studied and extensively shown to correlate to outcomes. When we look at like measuring muscle mass, actually the gold standard historically has been DEXA scan, which we always use DEXA scans to look at bone density, but actually you can get a relative skeletal muscle mass index from DEXA, and this can give you a sense for total muscle content of the skeletal mass. There's also these new things called bioelectric impedance analysis machines that you can buy, and you stand there and hold 2 handles, and it runs these alternating currents through and checks basically total body water content, which is essentially a measure of your fat-free mass. And then you can get a sense for sarcopenia from that. And actually, some spine clinics are using this around the country to assess sarcopenia in their patients. These are expensive, but they seem to be pretty accurate. So another way that people are doing this non-invasively. And then the other way is to kind of look at the imaging, right? And so a lot of this stuff actually comes from the oncology literature where they're looking at survival. Sarcopenia is actually a part of the disease state of oncology. So it's really important to them. They, you get wasting and cachexia and things. And not to mention every one of those patients has a CT chest, abdomen, pelvis that you can study. So they look at total muscle content in all the compartments. They look at visceral fat, and then they look at fatty infiltration in the different muscle contents. And all of these things can be measured, and there's cutoffs, and these are pretty well established. And this can be done with both CT and MRI, and there's pros and cons to both, but ultimately they're kind of measuring the same thing, muscle mass and fat content. But the reality is which of these do we use? We don't know. There's really no consensus, not just in our literature, but in any literature, of what's the best marker for measuring and studying sarcopenia. And this is a huge issue, right? Like if we're saying this is such an important thing and we don't even have a consensus on way to do it, is it physical performance tests? Should we be doing, bioelectric impedance analysis, or having some machine measure all of our MRIs and CTs and gives us a thing? And to kind of add insult to injury here, there's probably different types of sarcopenia that matter to us. So sarcopenia as a biomarker of overall frailty, you probably can measure with time up to go tests and physical battery. But when you study muscle content in the space around the spine, which probably has a direct measure to spinal stability and other things like pain, and matters directly to us as spine surgery, actually these things don't correlate. And this group out of HSS looked at the paraspinal muscles and atrophy, and there's probably a local effect from osteoarthritis of the facets and blood flow and other things that probably contributes, but these things don't even directly relate to each other. So other kind of classic measures of sarcopenia from prior descriptions don't even directly relate to what we're measuring in the multifidus and erector muscles. So I think we need to continue to work on studying these things and better figuring out what are we trying to figure out here. Are we trying to figure out how well a patient's going to handle a surgery, or are we trying to figure out how good their tissue envelope is around their spine that may help resist proximal junctional failure, adjacent segment disease, early rear operations, things like that we know are strongly correlated in other studies. And if you summate all this stuff, every single study shows the relationship. It's just there's no consensus on which one we should be using, which makes it really hard for us as clinicians to implement this stuff and know what should be the test that we should use, what are the cutoffs we should be using, and how is this going to direct our care. This is an example of a paper I think that is pushing us in the right direction. This is from MGH John Shin's group looking at it for metastatic spine tumors. And they use machine learning to do two things. One, we found that the most accurate measure from imaging is at L3. So this will automatically segment the whole spine and give a cross-sectional image at L3. And then it automatically segments all the compartments so that it can measure them. So no one's sitting there circling regions of interest and trying to use these programs and do this by hand. And so they actually showed that the amount of sarcopenic obesity here really impacted survival, not surprisingly. So I think this is the type of stuff that we need to be doing as a field to push ourselves in the right direction so that we can gain insight to feed these things back into our other predictive models. What about bone? So we all have a lot better understanding of bone health. I think actually many of us assess bone health in our clinical practices already. Where are we with this? So this is from 2021. This is the Red Journal CNS recommendation guidelines. Don't hold your breath, okay? So two things. We should be looking at it preoperatively. We should be getting a DEXA. So if they have a DEXA less than 2.5, relative Hounsfield units, these are if you take a region of interest and measure on your CT and measure the bone density based on the Hounsfield units. If it's less than 98 here, or some studies say 110, patient has osteoporosis. And if they have a vitamin D3 level less than 20, which I actually don't think there's a lot of data really to support that, but these are the recommendations. And so if you find these things, here's what you should do. You should counsel your patient on adverse events. What are you supposed to do with this, right? The other recommendation is that if you do have somebody with osteoporosis, you should have it treated, and that things like anabolic agents actually matter. So this is actually something that we actually have an actionable item that we can take, which is really nice about osteoporosis. We have something that actually improves outcomes, and this has been shown time and time again. But I mean, how crazy is this? Here's why. How's your DEXA scan? This is a patient from my clinic that had an osteoporotic compression fracture, and their bone density is completely normal. You can see the kyphoplasty, one level above what was being measured. DEXA scans don't even predict what they were designed to do, which was to predict fractures. They are bad studies, especially in the spine, and especially the aging spine, and particularly in patients with deformities and scoliosis and degenerative end plates, because it artificially increases the number. So we often use the femoral neck because it's free of that, but even that has its shortcomings. Now, we've been working on building a adult spine deformity database here, and this is still a work in progress. We've identified about 120 patients with more than 2-year follow-up here who had thoracic to pelvis fusions, and you can see the breakdown of upper thoracic and lower thoracic. And even despite how talented the surgeons here, our reoperation rate for mechanical failures is about 35%. And the breakdown of PJF and pseudoarthrosis is here. But how well does DEXA predict this? Not. Pretty much about as good as a coin flip, even if you set it's a really low threshold here. So, this kind of just emphasizes, yeah, this is our main screening tool in our patients, but it really fails to meet the mark. This is a really great study. Ben Elder and Paul Anderson kind of led this work. They looked at a few hundred spine patients that basically they used 4 different analyses of bone density. They took just in group 1, basic DEXA. Group 2, they used the CT Hounsfield units. They used a cutoff of 110. I think that's more common. Probably has a higher sensitivity or higher, ability to catch these osteoporotic patients than a lower number. And then they used this National Bone Health Alliance definition, which included DEXA, a history of a fracture, and then this thing called FRAX scores, which were a tool that was designed to predict 10-year fracture risks based on the factors kind of shown in the top right. And then the fourth category was the NBHA Group 3 plus CT Hounsfield units, plus if they had a trabecular bone score, which trabecular bone score is an add-on that you can do to DEXA that looks at the microarchitecture of the bone, as shown here in the bottom right. And they said, okay, well, how well do these things actually do in predicting osteoporosis? Well, DEXA predicts it about 25% of the time. So you're missing 75% of patients with osteoporosis with DEXA alone. Hounsfield units, so I thought these were so much better, but yeah. Fractures, presence of fractures. 36% had Hounsfield units. Identify it. Now, if you add the kind of combination of these things, you start to increase it. So now we're talking 75%, and then 82% with all of the above, trabecular bone score, and basically any of these things. So, and then they posted this illustrative case that shows really nice reconstruction. Can't really fault them for hitting their alignment goals, L2 to pelvis, but an early failure fracture needing to extension. And you can see here, despite the normal DEXA scan, low Hounsfield units, bad trabecular bone score. So this is kind of the stuff we're talking about. Now, in the last 5 years, we've also described this thing called a vertebral bone quality score. This is an MRI-based measurement of fat content using T1 signal. Okay, so basically use a T1, measure the amount of marrow fat with that, and you can maybe get a surrogate measure of osteoporosis. And this has got tons of papers out in the last 5 years. Why? Because everybody's got an MRI, everybody's got a med student. Pick your outcome you want to study, and you show that there's a difference, right? So how actually can we use this? And so the problem with MRI is that there's variable signal intensities. There's not a calibration in there like there is with CT in the same way. So you have to have a way that you basically zero it. And so if you measure the CSF signal and divide by that, you can kind of zero it. So we actually sought out to study this, and Adicia, one of our students this year, did an amazing job. She pulled all of the papers that have been published on this in the last 5 years, and we collated them, broke them down by the outcome that they studied, and everything's been studied. Even in pediatrics, they've looked at this. And you can see they've predicted osteoporosis with this, so cage subsidence with all the different inner bodies, all of them. But look at these numbers. They're all over the place. What number vertebral bone quality score do you use? 3? So like, for instance, this TLIF study showed that the ones who had subsidence had 3.8. This one said 2.96. Well, the next one uses 4.73 as their cutoff. So what this just shows you, if you look at, screw loosening, proximal, they're all over the place. And so what we actually concluded was that there's so much variability in the scanners and the brand of the scanners, the settings, MRI, all these variabilities make it too inconsistent. And so while locally you may be able to find a difference in some outcome based on the thing you're studying, we're not going to be able to take this into our clinic and make a measure and say, oh, this person had a 3.1, they're osteoporotic, in the same way we can with Hounsfield units. So too much inconsistency. We partnered with Wendy Gibbs, who's a neuroradiologist at Barrow, and she said, this is really a consistent finding across all the MRI-based bone measures. And so we're going to publish that. I think, whenever you get a ton of new papers like this, it's great to summate that data and actually show that this is something that really leaves a lot to be desired. And here's an example. This is looking at it at PJK out of the Mayo group. Basically, Hounsfield units didn't correlate at all with their vertebral bone quality score. They're completely different measures, and it did a much worse job of predicting PJK than Hounsfield units did. So I would turf that. I wouldn't start making MRI measurements of your bone quality score anytime soon. So I think that CT is probably going to be the mainstay measure. And can you take this further? So we are working with a group called On Diagnostics, led by a guy at Berkeley, Tony Chiavini. He started this company, and basically they are making more advanced calculations from the CT that we already have. So they'll make volumetric measurements of the bone Hounsfield units, essentially. And then they'll also use finite element analysis to simulate a fracture and see how much resistance the bone has to fracturing, so that you can get a really good sense, which is practical to us because half of our complications, especially in deformity, are fractures. So this is a really cool thing, and this has been shown with one other study in lumbar degenerative patients to really strongly predict the presence of reoperation or new fractures after surgery for lumbar spinal fusions. And we're actually hoping to send our deformity database to have this studied, which is really cool. And we're hoping that this will provide a better kind of answer for that. The SRS has made this a priority. So they've started this adult spine deformity task force on senescence that's been led by Bobby Slack and Chris Ames and Fran Police and a bunch of others. And I've been working with them to kind of write some of the state of the art for different applications of this. How do we study the aging spine better? One of the areas that we've identified is similar to what they're doing to advance studying of the imaging we have already, to potentially maybe use machine learning to advance this. We would call this, maybe in a hot way, radiomics. But this is basically using machine learning to analyze CT scans and other radiologic surveys that we already have to see if you can pick up signals within the imaging and find actually characteristics from that may be more beneficial. Here's an example of a patient paper that was just published out of China, where they basically looked at quantitative CT scans and the presence of osteoporosis. Now, the problem here is they used DEXA as their defining of whether the patient had osteoporosis, which we know is a problem. That's the whole reason we're doing this. But neither here nor there. The proof of concept is they were able to take a radiomic survey of a radiologic CT scan and then combine that with clinical predictive machine learning. So they took like lab values and other predictive factors that they found were predictive of osteoporosis, and then combine them together to actually create a really good model that predicts osteoporosis in their population. So not the best thing to test this against DEXA, but you could see the application here building on what we've done before, machine learning, adding advanced radiomics to that and improving our predictive analytics. And this is kind of my 1,000-foot view of how complex all of these things are. Basically, we know that these things are feeding into a Frailty syndrome, which we can potentially measure with machine learning, but we also know that these things can be measured in our patients on imaging, and doing more advanced imaging of that may help us get better measures that we can then feed into those models to get that AUC even higher and higher and higher. The problem is a lot of the things that we do have implications on this, right? A lot of our patients have stenosis or weakness in their legs, which then impairs physical function, which then impairs their muscle content and all of these things. So it's a very complex interplay of things. But this is kind of what we need to be thinking about as a big picture. For that last one was DEXA. So if it's only picking up 25 or 50% of the actual osteoporosis, it's not going to really help us much. The whole point of that study was to get rid of DEXA, and they used DEXA as their primary outcome. But the last thing I think that we'll add to this, and this is a area Dr. Shear is spearheading with our biobanking, something that I've been studying specifically with bone, is we've been taking samples from the bone, the vertebra and vertebral bone marrow, aspirates, and blood on lumbar spine fusion patients, and seeing if we can find protein signatures that correlate with bone health. And again, to your point, what do you use as your primary thing? And so I was like, I can't use DEXA. The whole thing's going to be flawed right from the get-go if we are comparing against DEXA. So this is actually what brought me in to start looking at the BCT as our primary outcome. And by the way, BCT is FDA approved. So actually Medicare will pay for it, and you can use that to justify medications preoperatively. So if you have a patient who is failing to meet the kind of DEXA qualifications, but you can tell on CT that they're clearly osteoporotic, you can actually send this to them. It's like $275 for them to run it. Medicare typically pays for it. Otherwise, it's out of pocket probably. But this can justify patient having osteoporosis needs preoperative treatment, especially for bigger surgeries. But again, here, the poor relationship between DEXA and BCC just highlights further why I can't use this as a primary outcome for our tissue studies. But here's what we found in a kind of our prelim analysis that we used as preliminary data to submit for a grant to the NIH. But basically, we looked at all three tissue compartments and found proteins that were different for osteoporotic patients versus not for both the bone marrow, and serum. And we were able to identify 8 proteins that co-localized between all 3 compartments, and the radiographic measurements that basically suggested that these proteins have altered levels in the patients with poor bone health. And so I won't kind of belabor that, but some of these are adipokines, not surprising, like adiponectin. Some of these are cell adhesion molecules. Some are inflammatory molecules. So, this is not really meant to be like, know all these things, but this is kind of where we're hoping to go with this. Identify protein markers, tissue level data, multi-omics that we can then feed back in, and not just have radiomics be this, but combined of these things, and really start to predict better who is going to have a good outcome and who's not. So kind of in conclusion, I think that our priority here should be to build and create clinically integrative machine learning models, stuff that we can actually use. We got to stop just publishing papers that show a difference. We need to take things that we're actually going to be able to implement into our clinic. And we also need to do this for spine-specific outcomes. We can't be relying on data from cancer studies and COPD studies. We need to be looking at it for patients who have complications, who are having spine surgery, so that we know and can create really accurate cutoffs and thresholds, and pick and choose the sort of measures that we're going to actually be able to implement successfully in our clinical practice. We need to add radiomic and tissue level omics data, and all of these things need to be in a way that we can make them actionable, things that we can do preoperatively to change the outcome for our patients. It doesn't do you any good to predict and just know. You got to be able to do something with that, whether it's preoperative bone health treatment, prehab, bone growth simulators, adding rods, adding more BMP, whatever it is. We've talked about this stuff a lot, but these things have to be actionable so that we can actually change the course of what we're finding. So I want to thank everybody that's helped. I want to thank for your time. I know this can be a dry subject sometimes, but it's a real honor to present to you all, and I'll take any questions. Thanks.
Dr. Walker, can you hear me?
Do you use Townsfield? Like, how would you describe your clinic, knowing all this data? Who do you choose to send to the rheumatologist or the endocrinologist?
Yeah, that's a great question. And I know we have a question online. I can hear you. Hold on one, because we're getting a question in the audience, and I'll take yours next. I think that this has been a struggle because the question from the audience is, what am I doing to evaluate bone health and in my practice? And is it DEXA scores or whatever it is? Right now, we've been relying on DEXA as a first. We get DEXA on everybody because ultimately that's going to dictate right off the bat, whether we can get treatment paid for. One of the things that's really interesting is a lot of patients are going on things like Prolia, which probably actually doesn't help fusion. It probably is an anti-resorptive medication, probably may actually have negative impacts on bone healing. It might make the bone harder or slow the decay of osteoporosis as a pathogenesis, which could be helpful for fractures. But an anti-resorptive treatment in the setting of fusion might not be the best thing. We don't know that. So we really need to push to get patients on Evenity, Tymlos, and Forteo. And I know this is CME, but I don't remember all the paratides, so forgive me for using the names. But the only way you're going to get that paid for is by having either a history of multiple severe fractures. So one insufficiency fracture is typically not enough to have insurance pay for it, or you have to have a DEXA score less than 2.5. So I think that that fails to meet the mark a lot, though. And so we'll have patients who are routinely measuring Hounsfield units for and identifying some osteopenia, basically osteoporosis. And for those patients, I have just started trying to send this BCT analysis to see if we can use that to support more patients getting the treatment. Otherwise, it's really hard because you're sometimes forced to kind of go down let's prove that they have some fractures. Sometimes you're like squinting at a Schmorl's node, so you can call that an end plate fracture, stuff like that to really get things pushed. And if you're doing a big surgery and you can tell their Hounsfield units are low, but their DEXA is negative 2.3, how good is that, right? I mean, it's pretty clear this patient's at an elevated risk of PJK and PJF, and maybe that may push you to not do the surgery right now. But that's kind of the why for me. That's what we need to be getting to. My hope is ultimately with the tissue level data that we can create blood tests that we have that become markers of bone health, things that we can order as a blood test preoperatively, like vitamin D we do, and then say, hey, this person's got osteoporosis. They have a resorptive issue, or they have this problem. And so it's a huge struggle right now because we even often identify people who are osteoporotic, but we can't even get them treatment. There was a question on the virtual, if you want to repeat that.
Yeah, Dr. Walker, can you hear me? This is Jens Chapman in Seattle.
Hi, Dr. Chapman, thank you.
Yeah, thank you for this fantastic lecture. I love the comprehensive overlook, and it is such an important topic. It can't be overstated. I'm going to make a quick pitch and then morph that into a question. So as the senior author of one of those risk triaging tools called Spine Sage, done in my UW time over 10 years ago, I find one very important value in the graphic display that we have. And I still use it to show patients visually what the complication rate is, and it's tied to the invasiveness of surgery. So the numbers for patients and their families mean very little. This is the Donnie Kahneman kind of a gambler's mentality that seemingly is pervasive in American patients. The visual printout is very, very impactful, and I actually print that out and put it into my Epic notes. So the key question to you is, who actually benefits from this risk triaging? Because we still have something called patient autonomy. And does this benefit patients and their families, or is this something that in the future insurance companies or hospitals will use as a tool to decide on surgery? So how does patient autonomy and the decision-making autonomy get combined with risk assessment tools? Thank you.
That's a great question. A couple points to that. First, I think that the number that you receive is hard to interpret, and I think that goes for the frailty indices for all of these things. How do you say if a patient has a 20% risk and another patient has a 12% risk of, say, infection? How do you deal with that? And for me, I look at everything as a preoperative calculation of their tolerance, their ability to withstand a certain amount of surgical invasiveness, as you suggested. So I think what we need to do, the part that we can change as clinicians, is to say, okay, this patient's tolerance is a lot lower. We can see that quantitatively. Let's change the surgical invasiveness here. and let's maybe offer this patient a one-level decompression or fusion instead of treating their scoliosis. Let's really minimize what we're doing here, even so far as let's just do the decompression instead of a decompression and fusion. I think that's the value there. I think you can't override patient autonomy. I think it allows you to counsel patients better. And I think if patients are miserable enough, they probably still, in a lot of instances, even if they know their risk is higher, will proceed with an operation. So that's a grayscale that makes it very difficult to answer that in a black and white way. From our standpoint, I think that there's a lot of value, probably at least on the decision-making standpoint of, we're talking about going into bundled payments, especially with Medicare for these things. One of the key drivers of cost is readmissions and things like that. And we were just talking about this. If I can look at a patient and say, this patient has a 75% chance of going to rehab or being readmitted, perhaps this isn't necessarily to say they can't have surgery, but how do we allocate more resources to them? Maybe keep them in the hospital a day or two longer so they don't get readmitted. Maybe have them have a shorter interval follow-up at 3 days, 7 days, 2 weeks, instead of just seeing them a few weeks later. How do we take this data and then actually inform a change that's actionable? And I think that, by kind of leading this way, I think we'll be able to have a better positive influence, and than just having insurers or hospitals say, we can't operate on that person. So I hope that answers your question. But our goal really with a lot of this EMR-based machine learning is to actually allow us to do what you guys are doing with the spine sage and actually integrate it into the EMR so that when you go to do the surgery, that stuff that's already there can be actually interpreted in some sort of way. It doesn't take any manual labor to plug in all the data points, and you can actually see it and then use that to triage patients.
Corey, thanks for this amazing talk. There's not that many grand rounds lectures that I get where I literally don't know much about it, and then you come out of it saying, wow, I feel like I've been updated. I echo what Bay has said, and also I'm very excited that the SSF people are on here today to kind of share this with you, because this is truly a CME educational lecture that was just outstanding. Sarcopenia to me it's still this foreign kind of concept. So if we have osteoporosis, or we diagnose osteoporosis, we give them their bisphosphonates or their treatments, medical treatments. But what do we do with sarcopenia? Because in your talk you were saying they go hand in hand, and I don't actually even know which is more impactful. Is it sarcopenia or osteoporosis? So if you see someone who has potentially sarcopenia, and then as my head is swirling in this world of like Ozempic and all the GLP agonists that reduce lean muscle mass in general, I feel like we have no treatment even if we identify sarcopenia.
Yeah, I think that we definitely don't have medical therapy in the same way. But I was just talking to my uncle, and he just had a knee replacement, and he was like, I spent 6 months on the stationary bike before surgery trying to boost up my muscles so that I'd have a better recovery. I think the prehab type of stuff is really well informed in the orthopedic space. And I think sometimes there's a little bit more time to make these decisions. Like if we have a patient with a lot of their conditions that we treat, they need surgery, and they're not going to wait 6-8 months to get it. I do think that there's an opportunity for us to study these things better, whether it's anabolic medications like HGH. There's kind of anti-senolytic medications. So there's a whole world of gerontology here that looks at slowing the processes of aging and muscle wasting, muscle loss. Even things like elevating your protein in your diet, things like metformin, other medications that probably have some sort of benefit to our patients that we're not even tapping into. So that's a big part of it. And then the other part is, how do we measure whether that's actually having an influence? And that's what's really challenging. You could send somebody to 6 months of prehab, but how do we actually know if it's helping? We don't have a measure. And so, at least with bone density, you can go repeat the bone density imaging measure, but it's a little harder with the sarcopenia. So I totally agree. the data that you have is more informative. And I think in a large way, osteopenia has been relegated more to be a biomarker of frailty rather than a disease state that we're treating actively.
So Corey, thank you for educating me. I love how you took an honest look at some of these frailty indexes and questionnaires. But the truth is that these get people their CV boosted, they might get them a residency, they might get them grants, but they're not really helping people yet because they're too complex. I suspect what your uncle found is true. What just come down to is tell people, have a good diet, go to the gym. You know, what you need to do is something simple that makes them better, not just be lost in academia.
Totally. All right. Well, thank you again. We really appreciate everybody.
One second, can I echo on that? So there's so many nuggets in there that are so important as take-home messages. The causal interplay of skeletal muscle health and bone health it cannot be overstated. Dr. Walker, this was gold right there. This is fantastic. What I am postulating going forth from this is, again, looking at a pre-operative response curve of a patient in terms of being compliant with the prehabilitation measures that you mentioned, increased protein intake, compliance with a prehabilitation recumbent stationary bike, the simplest thing in the world, opiate reduction, although that's still questionable. So literally a checkbox of these things. And if they have a high compliance curve, my hypothesis, they will do way better than patients who passively slither into this massive polytrauma of a surgery, however you want to do it, right here in front of you on Beverly Hills Drive, just get smacked by a surgical car and then somehow try to get out of that mess. So I think that the take-home messages are really tangible, but the hypothesis I have is that the mental aspect, the ability of a patient to actually participate preemptively in this prehab process would prognosticate better outcomes. That's just my hypothesis. I want to throw it out there, and it's based upon your excellent lecture today, for which I thank you.
Thank you. Yeah, really insightful. I have to think about a way to study that. Well, thank you again. I appreciate you all being here, and I hope you have a great day. Take care.